guys, we're going to start our heart failure video. So this is part 1, and we're kind of excited. All right, so let me grab my marker. Here's my marker. Okay, now one of the first questions we want to ask our heart failure patients is, let's see if you can fill in the blanks. How many blanks do you blank with? Now this could be interpreted a variety of ways, right? But we want to know second word. That's what we do at night, right? We're in our beds. Sleep, okay? So how many blanks do we sleep with? What do these folks have troubles with? They can't really sleep laying flat, right? Otherwise known as orthopnea. So they got to prop themselves up on pillows, right? So how many pillows do you sleep with? That's a really good question to ask your patients, because that kind of gives you an idea of how far progressed or how well controlled their heart failure is. Okay, risks and or causes of heart failure. Okay, so heart failure is where the heart has been pumping too hard, working way too hard for way too long, all right, for tons of different reasons. So there's all sorts of different pathologies that can make the heart pump too hard for too long, and then what happens is it gets tired out. And just like any muscle, when it gets tired out, it doesn't work as well. And then we get what's called a boggy heart, right? Where it's just kind of squishy gushy, it's not really pumping efficiently. Okay, so all these things will end in the same problem, where the heart is working too hard, and then we develop heart failure. So the first thing starts with an H, hypertension, right? So hypertension, for whatever reason, is going to give us heart failure, because eventually, over a long period of time, untreated, it will develop into heart failure. Because if you can imagine all of your blood vessels now pumping harder, faster, it's going to make the heart work harder, right? Because it's going to increase preload, eventually increase afterload, and then we're going to have a boggy heart, right? Okay, so there's some other things. These are all the diagnoses. I kind of grouped them in their corresponding groups. So these are all of our risk factors that have to do with the heart. Okay, so coronary artery disease. I always say cardio first. Coronary artery disease, or an MI. Okay, these kind of the chicken or the egg kind of thing. Or this one might cause this one, might cause this one, this one might cause this one, right? It all ends up in the same boat, and that is in heart failure. Okay, this one has to do with my buddy Bobby Darin. Okay, he's one of my favorite singers. He sings a song called Splish Splash, among a bunch of others. So he lived in the time when we didn't treat strep throat with antibiotics. Nowadays we treat it with antibiotics, so there's no big deal. Well, he got one of the rare complications of untreated streptococcal beta hemolytic strep, right? And so it developed into scarlet fever, which is nasty strep throat untreated with the rash. And then that went even further. You can still treat it with antibiotics in that point, but then it went even further, and it deposited little bits of vegetation, little tiny bits of the bacteria deposited itself somehow on the valve leaflets in his heart. Okay? So then, what happens when that's going on? If we have valve problems, valve defects, whether they're congenital or whether they are acquired, right? So now we have a defective valve. So it might not allow something to get through it. It might be somewhat stenosed. That's when it's hard to push things out. And then, or it could be regurgitative. Then that's when it is not closing all the way, so then it allows backflow. So if that happens, for too long, you develop, and it goes untreated at the valve defect stage, then you develop heart failure, okay? And then if heart failure is untreated, like in his case, right, in the 50s and 60s, then you die rather young, okay? And he died under the age of 40. Kill someone, right, or cause heart failure. All right, now we got all of our funky rhythms, right? So we got AFib, we got all kinds of stuff, otherwise known as arrhythmias, okay? Then we got family history, so maybe someone in your family has a history of coronary artery disease, okay? So then that puts you at risk, right? Some people don't have any of these. This is the only thing you got, just that one thing. And when I talk about family history, the only thing that we as providers necessarily care about is a family history of direct relatives. So that just means mom, dad, brother, sister. That's it. We don't care about grandparents. We don't care about aunts and uncles. None of that. We want to know mom, dad, brother, sister. Okay? Plain and simple. All right. Now we're going to talk about the risk factors for heart failure that have to do with things that we do. Things that we might put in our bodies, whether they're for a good reason, treatments for different diseases, or choices that we make, things that we put in ourselves that aren't really good for us, right? So here we go. Those are otherwise known as toxins, okay? So it might have to do with what we give people for cancer. Chemo, that is considered a toxin, right? It might be toxins that are illegal, illicit drugs, right? Or it might be alcohol. And we're talking about prolonged use. We're talking about a long time, right? Lifetime use, right? Some serious heavy duty stuff, okay? And then chemo, obviously, is a toxin, and it is taxing on the heart as well. Okay, now, what's other choices or things that we do to ourselves? Sadly, obesity is one of them, right? So when you have a large amount of adipose tissue around your middle, then what happens is that increases our interthoracic pressure, right? Well, then the heart has to pump even harder against that pressure. So you've got tons and tons of pressure pushing on the heart, right? And then the heart has to pump even harder and work even harder to get around and get through that increased pressure in the thorax. So that's a bit of a problem, right? So increased intrathoracic pressure. Okay, so that's not good, that's not great. All right, now this is another thing that we do to ourselves, but usually in our current world, only girls can do this. We haven't quite got to the point where men can do it. So it is when you become pregnant, or it can also happen in the postpartum time frame. So what do you got going on in pregnancy? We got another human. Well, that other human brings with it a few extra things, right? It brings with us, namely, extra blood. So we've got all this extra blood volume going on with the baby. So that puts a little extra stress on mom's heart, right? And then postpartum, what happens in postpartum? Well, postpartum, it's the opposite problem. Postpartum, the mom was dealing with a really large blood volume, and now you've taken away a bunch of that blood volume within a matter of seconds, as soon as that baby is passed, right? Well, now you have a dramatic decrease in blood volume. And so sometimes the mother has a really hard time compensating for that drastic change. So the drastic increase and then the drastic drop. So that puts a little bit of extra stress on the heart. All right, now we've got our other diagnoses, kind of their own thing or miscellaneous category, right? So we're going to talk about endocrine disorders, endocrine diagnoses, and there's two specific ones that will affect the heart and potentially cause heart failure if they go untreated. And that's our thyroid. So we'll put thyroid, right? Okay? So hypothyroid and hyper. Okay? So if you've got something in your blood, too much thyroid hormone, for whatever reason, then your heart's going to be pumping super hard and fast, right? So then the heart's going to be working harder. If you don't have enough, it's going to be super duper slow, but that also causes undue stress on the heart itself. Okay, now, so another condition that doesn't really fit in a category that they're finding out, if sleep apnea goes untreated for a long time, it actually puts you at risk for heart failure. Because if you think about it, depending on how serious it is or how severe it is, the more nights you spend in a hypoxic state, right? Because when you're sleep apneic, you're not getting enough oxygen because of the breathing issue. So if you're not breathing, you're not getting enough oxygen. If you don't get enough oxygen over a long period of time, they're finding out it puts you at risk for heart failure, okay? So any kind of hypoxic state that's not fixed, right? And then we have any sort of state or medication that puts you at increase in water and or increase in sodium retention. So there's tons of medications that do that. There's a lot of different, diets that do that if you're a heavy salt user like myself. So that's going to be that will be my Achilles heel, right? So that will be my risk factor for heart failure, is I really like my salt. Okay, now let's talk about our symptoms, signs and symptoms of heart failure, right? What do these people look like? Well, okay, so these are in varying degrees. So we got our mild people, got our moderate, and then we got our severe. Severe, this is kind of like ER, ICU kind of stuff. Mild, this is where they like to keep them. When they're maintaining their heart failure, they'd like to keep them in this range up here, okay? And hopefully intervene when things start to get worse. Okay, so I've divided them up into subjective symptoms, so that's what the patient reports, remember, because it's subjective. And then we also are objective symptoms, so that's things we can hear with our stethoscope, observe from across the room, that kind of stuff. So these are things that they report. So we got some shortness of breath at what? Do they have shortness of breath at rest? Not usually, that's more in our moderate category. So they usually have shortness of breath on exertion, otherwise known as DOE or dyspnea on exertion, okay? They might feel super dumpy, otherwise known as fatigue, right? They feel dumpy, droopy, fatigued, all right? These guys are also starting to show a little bit of nocturia, right? So they're getting up a little too many times at night to pee, okay? That doesn't necessarily have to do with their prostate or an overactive bladder. It has to do with their heart and the amount of fluid that they've got going on in their body. Then it gets pushed to the kidneys at night to try to deal with the excess fluid. Okay, now that brings us to weight gain, right? So as we get more and more fluid that our kidneys are going to have to deal with, sometimes they don't work as well as they should because they're being overtaxed. So then we gain weight. And the usual rule of thumb for calling your provider is if you've had a greater than 3 to 5 pound weight gain, okay? And that's in like a week, right? So that would be something you'd want to tell your patients to talk to their provider about. All right, now objective. Well, what do we got in objective? What can we see? Well, we're going to see some peripheral edema. Okay, so we got peripheral edema in their legs, right? That's kind of where it starts, or in the feet, and then the ankles, then the legs as it climbs up and up. So that's peripheral edema. We might see some jugular venous distension, and this might happen in varying degrees. So depending on how bad their heart failure is, it might, get a little bit more pronounced. Okay, then we got some tachycardia, right? So what's the heart doing? It's having to pump really, really hard because it's not working efficiently. So now it's got to go faster so it can get the same job done that it was getting done before when it was going slower. Then we get an increase in blood pressure. Okay, so that's kind of why these folks get a little hypertensive. Now, they may have had hypertension before. It's a bit of the chicken or the egg kind of thing. So they may have had a little bit of hypertension that caused the heart failure, and then now they've got hypertension in heart failure, right? Okay. So these guys also report an increase in weight as well, right? But this, okay, so this is something they report, but then you can also measure it at the office. So it's both a subjective and an objective symptom, right? And then what do our lungs sound like? So when we listen to them with a stethoscope, they might have some crackles, right? And crackles are best heard down at the bottom of the lungs or in the bases, okay? Then, what does their heart sound like? So you want to hear the normal S1 and S2. That's good. You don't want any more than that. No more, no less. You want S1, you want S2, the lub-dub. Then now these guys are starting to get what we call an S3 gallop. So that's an extra beat at the end of S2, okay? And if you truly heard a true S3, it's actually pretty interesting because you'll never forget it once you hear it. Okay, so now these are our moderate people. They're starting to, now they got nocturia, but guess what else they got going on at night? They have a nocturnal cough. So now they're coughing at night because they're dealing with extra fluid in their lungs that then is going to make them cough. So now these guys are short of breath. Remember, these guys were short of breath on exertion. These guys are short of breath at rest. So they're just sitting there marinating, hanging out, and they are plumb tired. They're short of breath. It's like they ran a marathon, but they haven't. They're just sitting there. Okay, so now we got PND, otherwise known as paroxysmal nocturnal dyspnea. Okay, now you might say, Genevieve, well then what's the difference between that and the nocturnal cough? It's very different. So you can have a nocturnal cough, but not everybody has the PND. PND is where, paroxysmal, right, is where it comes and goes, but it's kind of a sudden thing, right? And it's at night, and it's difficulty breathing. So it would present like this. You would ask your patient, how do you sleep at night? You don't really want to ask them too many questions because you don't want to lead the witness, so to speak. So you're going to ask them, how well are you sleeping at night? Sleeping okay? Do you wake up in the night? And they might say, yeah, I wake up a few times at night. Well, how come? Why do you think you wake up so much? Well, and then they might describe, I wake up suddenly with the feeling like I cannot breathe and that I have to cough, right? So they will suddenly wake up with a feeling like gasping for air, cannot breathe. They'll have to stand up, sit up, and then cough, okay? That is paroxysmal nocturnal dyspnea. It will come and go, obviously get worse as their disease is worsening. So that's PND. All right, now these guys are going to be looking a little worse than these guys, right? So we're going to have worsening of our edema. Uh-oh. Sorry, guys. It's going to now include the scrotum. Yikes. For men and women, it will include the entire sacrum and get worse and worse and worse, right? So now our edema travels up the body, right? And now we're getting nsaids, okay? So now you've got issues with the belly getting bigger, kind of that pregnant belly look. That's more of your ascites, right? That's when the liver's starting to go. So then we got, obviously, they're tachypnic, right? So they're going to be increase in respirations. And then these guys are also going to be tachycardic, right? So their blood pressure is going to be climbing even higher, right? So here we were tachypnic, here we were tachycardic, right? Sorry. Here we are tachycardic even more, and now we're even tachypnic. So we're breathing fast, our heart's going fast. Up here, the heart was just going fast. But now we got all the vitals going up, right? Except for oxygen, right? Okay, so now these guys are pretty bad off. So this is where you might see them in the ER or the ICU. So now their cough, remember they have a nocturnal cough? Well, now it's progressed down to somewhat of a productive cough, okay? So that cough is nocturnal, but then it produces sputum, right? Because that's the definition of a productive cough, makes sputum. And then, what does that sputum look like? It is pink and frothy, right? So now we're kind of progressed over to some acute pulmonary edema, right? Now, what about these guys? So same, severe, right? And then now we're in our more objective symptoms. So you're going to see them get really cyanotic, cyanosis. So think your Smurfs, right? And then your ascites is going to get worse. Now your edema in the scrotum and or the sacrum, right, is going to get way worse and progress to what we call anasarca. Anasarca is horrible edema, super severe, usually in the pelvic area, okay? And then we get down to hypotension. So this is kind of where the heart is starting to give out. So it's been pumping hard, working really hard, and now it's plumb tuckered out, right? So now we got some hypotension, and then our heart rate, we're going to be tachy. So you're going to have a high heart rate. All right, and now what's going to happen with our level of consciousness? Level of consciousness is going to go way down. And why is that? Well, we're tired out. Our heart is not doing well. We're going to tire out mostly because of a lack of oxygen for too long. Okay. So now let's talk about our diagnostic tests. So diagnostic tests in the ER or possibly in the ICU as well, the ways that we try to shake out what's going on. So we want to use these diagnostic tests as that to diagnose, but we also in the ER, remember, the ER's job is to rule out the bad stuff. So while we're trying to figure out a diagnosis, we're also ruling out the bad things. Okay? So we got a few things, right? Well, how do we diagnose? How do we diagnose an MI? Remember from last week, how do we diagnose an MI? What's our key gold star, right? It is an EKG, 12 lead, right? Our 12 lead EKG. So we're going to try to rule out an MI, right? Okay. We're going to try to rule out some arrhythmias. Oops, forgot my H. We're also going to try to rule out a little bit of left ventricular hypertrophy, which is probably the case if it's bad enough, right? Okay, and then we want to do a chest x-ray. But these people, remember, they can't stand up, so we can't get a tube view. So we got to get a portable chest x-ray, okay? And remember from last week, we want to rule out that dissecting aorta. We want to rule out an enlarged heart, which it's not going to be ruled out with these folks. It's big, right? It's going to be big, but we want to see how big. And then we want to look for some pneumonia, so some infiltrates, because that fluid possibly could have progressed over the fluid that's accumulating in their lungs, right? All right, now, how are we going to look at the heart valves? Remember over here, heart valve defects were one of the risk factors and causes for heart failure. So we want to get a good look at those heart valves. Also, we want to figure out what their ejection fraction is, right? That's the amount of blood that's being ejected. Now, the stroke volume is the amount of blood being ejected with every beat, but our ejection fraction is a ratio, right? It's a percentage. So we want to know what the EF is, right? We also want to know our, let's see, so this is an echo, right? A transthoracic echo. So there's two different ways you can do an echo. You can do the transthoracic echo, so that's just regular echo, right, with the ultrasound probe on top of the chest. Or you can do a TEE, which is a transesophageal echo, and that's where you do conscious sedation. They put a scope down you just like an upper GI, but the cardiologist is doing it. They put the scope down, then they put an ultrasound probe down into the scope, and they look at the heart through the esophagus. So that one is a little bit more detailed, right? And that would be, you get some, some better information. All right, so we want to know ejection fraction, we want to know heart valve problems. So our normal ejection fraction for a healthy adult would be hopefully between 60 and 70%, okay? In these heart failure people, sometimes they're as low as 25 in their acute exacerbation. So sometimes not so great, okay? Just to give you an idea, our arrhythmia, like AFib, right? AFib will decrease your ejection fraction by 25%. So that's pretty significant. So you can see how this could be, a major problem, right? And then if our valves aren't working right, we need to see which one it is, because we want to get to the root cause. Because if they can figure out which valve it is, and if it's bad enough, they can surgically fix it, and then hopefully preserve some heart function, right? Okay, now stress test. Now this is usually not done in the ER. Usually this is done once they are admitted to the floor, ICU, or they also do them outpatient. But in this kind of situation, the patient would not be outpatient, right? Because they're in an acute problem. Okay, now let's talk about our diagnostic labs. What do we want to figure out? What's our really cool diagnostic lab or blood test now? And this measures, this particular lab starts with a B, and it measures our end diastolic volume, right? Okay? It measures our end diastolic volume. It senses an increase in pressure and an increase in stretch in the actual ventricle itself, right? So if you have an increase in pressure, an increase in stretch, then we can measure that by doing a BNP, either the brain natriuretic or the beta, whatever hospital. I think most hospitals are using the brain one. Now, just to give you an idea, for every 100-point increase in our BNP, right, and anything really under, anything above 300 is considered, somewhat indicative or quite indicative of heart failure. But for every increase in 100 points in our BNP, we increase our mortality rate by 35%. So that's not great, right? So that's kind of that's the correlation between the BNP and the mortality rate. So for every jump in 100 points, we increase our mortality rate by 35%. All right, how do we rule out anemia? We've already figured that out. How do we rule out infection? We already know this, right? We did this a couple weeks ago. We do a CBC because we can get a good look at hematocrit, hemoglobin, our whites. We can get a good look at our bands and our absolute neutrophil count, right? So we can really see, just make sure they're not anemic, they don't have some crazy nasty bacterial infection, right? Okay, now, BNP, not the same as a BNP, but a BMP, so a basic metabolic panel, okay? This is going to check our electrolytes, it's going to check our BUN and creatinine, otherwise known as how the kidneys are doing. Kidneys doing. How are your kidneys doing? Well, let's check your BUN and creatinine, okay? And also the GFR, right? That's all part and parcel to our kidney labs. All right, now, so we talked about an underlying cause of heart failure. We want to make sure that this is not the case. Because it can go undiagnosed. This particular thing can go undiagnosed for quite a long time. Remember our endocrine problem, our thyroid? So how do we measure thyroid? Via blood test. We check do we check a thyroid hormone? Well, yeah, but you check a TSH and then you get your reflexive T3, T4. But it's that TSH that kind of tells us, make sure they're not in hypo or possibly hyper, right? So that will rule out our underlying cause. Make sure it's not that. Then we get a UA. The heck Well, we also want to know, how the kidneys are doing on the inside, pre-renal, but we want to know how they're doing post-renal, how they're doing how much they're getting out, right? But specifically in our UA, we want to check a protein. You start spilling proteins in your urine, what does that say about your kidneys? They're not doing great. So high protein in a urine is bad, right? So high protein in the urine is bad, okay? That means kidneys aren't doing awesome, okay? So let's talk about our last, very, very last thing. What was it we were using lab-wise to make sure they didn't have an acute MI? Remember last week when we were doing our heart attack week? We checked troponin, okay? So we do this to rule out an MI. Now, in severe heart failure, just be aware that sometimes with severe heart failure patients, when they present, they can have an increased troponin, but that doesn't necessarily mean that they're having an acute MI, okay? So just be aware that that is a thing. All right, now go to our next video. So we're going to continue on and talk about our heart failure medications. How do we maintain heart failure at home? So this is home management, and this is without an exacerbation. This is how we maintain heart failure and manage it with home medication, right? So this is not an exacerbation. That's not how you manage exacerbations. So this is our home stuff. So you're going to see that a lot of them are on what's called triple therapy. That's kind of the new standard of care. A lot of these heart failure folks, they have to be on 3 different classes of medications to help manage, and with sometimes an addition of a couple other things. But okay, so first thing is we want to put them on an ACE inhibitor. Okay, so that's our angiotensin converting enzyme inhibitor. So it keeps angiotensin 1 from turning into 2, which is a potent vasoconstrictor, thereby lowering our blood pressure. Okay. Now, some people can't tolerate the ACE inhibitor because it increases the amount of bradykinins in their lung passageways, their airways, and so then they develop what's called an ACE inhibitor cough. And that's kind of a dry cough. It usually comes on within a week to 2 weeks after you start them on the ACE inhibitor. So then they come in, they complain about the cough, so then you switch them to an ARB. So then that's the angiotensin. So, angiotensin receptor blocker medications like Micardis. Okay, now our ACE inhibitors, they usually end in the RIL or the PRIL, right? Most common one that is prescribed first line is lisinopril, okay? And we stick them on lisinopril. There's also captopril. Okay, now we want to stick them on a beta blocker. That is our second of our triple therapy requirement for these heart failure people. So the beta blocker, right, does just that. It blocks our beta receptors in the heart. So it's going to lower blood pressure, lower heart rate, okay? They end in the OLS, the alls. So kind of the number one go-to is metoprolol, all right? Okay, now the one thing about beta blockers is they usually dump people on their butt pretty quick. So they make you really tired, make you exhausted, right, because they slow everything down. So the best way to teach your patients to take these is to have them take them at night. So that way when they're sleeping, the side effects are happening, and when they're awake and going about their day, the side effects aren't as bad. So that's why I usually tell people is to take them at night. Okay, now we don't give them, do not give a beta blocker, okay, if what? If we are in symptomatic fluid volume overload. Okay, so our fluid volume overload people, right, they've got crackles, they're dyspneic, they're short of breath, really bad in an exacerbation, right? So in a bit of a heart failure exacerbation or any evidence of fluid volume overload, even edema in the legs, we want to hold the beta blocker. Why? Well, the reason we want to hold that beta blocker is because the beta blocker is helping our heart, right, by lowering our blood pressure, lowering the heart rate. Well, it can actually worsen their symptoms during an exacerbation. Now, if you think about it, during an exacerbation, the heart's not doing great, and it is relying on those beta receptors to keep it going, to keep the heart going, to keep the heart pumping. And so if you suppress those beta receptors and slow them down, that's the only thing that was keeping them moving. That's the only thing that's keeping the patient hanging on. So now you can potentially make the heart do worse, then you lower your beta receptors. So now we're blocking our beta receptors, right? So we'll say beta receptors are now being blocked, which then lowers our heart rate and lowers our blood pressure even more than it would if they weren't having an exacerbation. Which means it could potentially put them into shock. So the really high heart rate, really low blood pressure, and then tank BP and heart rate eventually. So we want to steer clear of a beta blocker during heart failure exacerbation. Okay, and then the other part of the triple therapy is we want to put them on some sort of diuretic. Now, the diuretic that is now being used kind of across the board is spironolactone. Okay, it's a mineralocorticoid receptor blocker. Okay, it is. What does it do with potassium? Does it hold on to it, or does it waste it? Does it spare it, or does it waste it? Well, the other one is the potassium wasting, right? Our loop diuretics. So this one is a sparing. So it's going to hold on to potassium. Okay, and then these are some other medications that are used for treatment. Okay. So I'm going to add just this medication up here can be replaced for the ACE inhibitor or the ARB. Why would we want to do that? Well, our people of African descent, because of the way that they respond to an ACE inhibitor or an ARB, they actually don't work on them. And so, right, so we can't treat them, so they don't tolerate the ACE or the ARBs. So we really can't treat them with those, and so those are our folks, African descent. So usually we try to use hydralazine on them, and that will replace the ACE inhibitor for their triple therapy. Now, loop diuretics. Let's talk about loop diuretics. So they have been used a lot in chronic treatment of, fluid volume overload, edema, that kind of stuff. Now I say usually, because once you get involved with a patient like this that is on Lasix chronically, they will probably be having, if they're a heart failure patient, they will probably be seeing a nephrologist as well. And the nephrologist will be the one in charge of their care because the kidneys have to be really helped and taken care of. So usually we don't use Lasix chronically. Now I say usually, that's not the go-to medication anymore. Instead we use spironolactone. Okay, now, why? Well, because it's nephrotoxic. It can be. It can be nephrotoxic. So those are the drugs like the EX and the IXs. So Lasix or Bumex. Okay. Now remember, spironolactone was a potassium sparing diuretic. And we've got Lasix is a potassium wasting. So it gets rid of potassium, which means if people are on it, they have to take it with over-the-counter or prescribed potassium pills, right? 20 to 40, whatever milliequivalents, what they've figured out. Now, nitrates. So these two medications are used routinely. Our loop diuretics and our nitrates are used routinely, ER-ICU, for inpatient management of severe heart failure exacerbations. So the loop diuretics will help with that extreme fluid volume overload. So they're usually given IV. After you place the catheter, we give them an IV bolus of, between 40 to 80 of Lasix or Bumex to try to get rid of some of that extra fluid. Now, along with that, or by itself, you might start to see a new medication being used. Well, it's not new, it's an old medication, but we're going to be using it in a different way. So nitroglycerin is actually used in a higher dose IV, in an IV drip, higher dose than you would use it for a heart attack. It's now being given IV in a IV push. You can do IV drip, but they do it IV push as well, because they found that in an acute heart failure exacerbation, we need to decrease preload and afterload, and nitrites are really good for doing that, okay? So you might see that. That's kind of an upcoming medication. You might see it being used in conjunction with loop diuretics. Now remember, nitrates lower the blood pressure quite a bit. So in our heart failure patients that are presenting with acute flash pulmonary edema signs, their blood pressure is sky high, so a nitrate is okay. But if your patient is kind of decompensated heart failure, where they have extreme fluid volume overload and they have really, really low blood pressure, you want to really figure out what is the root of the problem, and then make sure that you are not so much giving this one when their blood pressure is too low. And also with a loop diuretic, it can lower blood pressure as well. So you're going to want to be careful. And so in those circumstances, a lot of patients will be put on pressors, or they'll be given a small fluid bolus, right, before, so that they can handle the medications to treat the heart failure exacerbation. So you'll mostly see a lot of that happening in the ICU, okay? Now let's talk about some of our patient teaching. We want to talk to them about managing their body weight, right? Well, how do we teach people how to manage their body weight? It's really hard, right? Because we like to eat. So a good way to do that, don't, teach them to go on a crash diet, just portion control. And so, how do we portion control? Well, one portion for me is the size of my fist. Simple. That's easy, because you can't get rid of your fist, it's always on you, so you just have people, measure their portions with their fist. Well, I'm going to make a big caveat for this, right? Because good luck in the US for doing this. Because all the portions that are given to us at restaurants, fast food places, are about 5 times what we would need in one meal, right? So, it's a bit of a losing battle, but we should, give it our best, right? Okay, now, we want to talk to them about fluid restrictions. They may be on, depending on how bad their heart failure is, they may be on fluid restrictions. They may also be on salt restrictions. And this may be all salt in their diet, or maybe the amount of free salt they're allowed to dust. So they may be allowed to eat a normal diet, but then they're just not allowed to use any salt at the table. They're not allowed to add any salt, extra salt to their meal, because they're getting most of it from their diet. So it kind of depends, and every cardiologist will put on some sort of a restriction in salt in grams. So like, under your 1 to 2, just depending on how they would like to restrict them. And then fluid restrictions, they usually go between 1 and 1.5, sometimes up to 2 liters, but that's kind of the high end. A lot of times in the hospital, you'll see them between 1 and 1.5 fluid liter restriction. Now, a lot of these patients, or maybe not a lot, but some patients don't count juice or alcohol in their fluid restrictions. They just think it's water. So you have to kind of specify with your order from your provider what the fluid restriction is. Is it just free water? Is it all fluid that they intake? Or, how are we doing this? So I've encountered some patients with severe heart failure who also enjoy drinking alcohol, which is fine, but they don't factor in the amount of fluid in the alcohol is part of the fluid restriction. So you need to kind of make sure that they understand that that fluid restriction also encompasses alcohol. Because, depending on how much they drink, they can kind of bump themselves way above their fluid restriction with the amount of alcohol they drink. So you might need to figure that one out. Okay, now, we don't want them to, what? If they are smoky, we want them to stop smoky, right? So no more smoky, okay? That includes regular cigarettes, e-cigs, vapes, whatever. So, right, because we already know that the chemical nicotine and a lot of the carcinogens, they harden the arteries, right? And form, more atherosclerosis, more inflammation. And so that's a huge stroke. So let's get back to exercise. So we don't want them to smoke anymore. We want them to exercise. Well, how much? You kind of want to ease into it, right? Because they're not in the best shape. So we want to have them exercise, work them up to 3 times a week, 30 minutes at a time, right? And this is a nice brisk walk, right? So we're talking about brisk walking, okay? And then they can possibly build up from there. Now we want to talk about daily weights with these folks. So have them, weigh themselves every day, right? And they're going to watch for any kind of increase between 3 to 5 pounds in 1 week. So if they have greater than a 3 to 5 pound increase in weight in 1 week, we want to have them talk to their PCP, right? Okay, now let's talk about meds. These are over-the-counters and prescription. And these are medications that we don't want to prescribe them, and we also don't want them to take over the counter. So these are some good teaching points before they leave the hospital. They need to know they can't do these things. So we want them to stay away, far, far away. And this also pertains to people with high blood pressure. So if you have high blood pressure, you also want to stay away from this over-the-counter painkiller, which is an NSAID. Right? NSAIDs at the kidney will increase, they'll make your body hang on to sodium, right? So they're going to sodium retention at the kidney, which then water is like its codependent little buddy. It can't go anywhere or do anything by itself, and so it's going to follow the sodium. So then it's going to cause sodium or water retention. So sodium, water retention, which means now we have extra blood or water, however you want to call it. We've got extra fluid, okay, which is now increasing our total blood volume. So now if we increase our total blood volume, body can't handle it, it's too much blood, so now we got to increase our blood pressure to compensate, which puts more strain on the heart. Let me tell you a story, a real life story. So I had a patient, and he kept coming back for really high blood pressure. So see him in the office, blood pressure would be above 200, could not figure it out. So he's on like 5 different blood pressure medications, trying to figure out how to control it. Then the last time I saw him, I started asking him about, different over-the-counter pain meds, if he was on anything. And he went to an urgent care for a knee injury, and they prescribed him Mobic, which is meloxicam, which is a prescription NSAID. Bingo. That's why his blood pressure was so out of control. He already had high blood pressure. He was already on 3 meds, but we had to add more because he was taking NSAIDs chronically, and we just didn't know about it. So good thing to talk to him about, okay? So then the next week, after I got him off the NSAIDs and talked to him all about it, we don't take it over the counter, came back, his blood pressure was 130. So I'm like, thank you. So so that's a really good point to teach people, because a lot of people don't understand, if I have an ache or pain, I can just take some ibuprofen. No, they can't. If you have high blood pressure or heart failure, you cannot take ibuprofen or any other NSAID, right? Okay, so the other medication, this is prescription only, and a lot of times it's prescribed for high blood pressure, but not for heart failure, and it's a calcium channel blocker. And the reason why it's not prescribed for heart failure is because its main side effect is it increases water retention. And so they'll get more edema. So it increases peripheral edema. That's one of the main side effects, is that they'll get some swelling in their ankles and feet. So we want to keep those guys far away, right? Feet, ankles, all right? And then the next thing is we want these guys, this is an over-the-counter medication, we want these guys to stay away from all over-the-counter cold meds, and specifically the decongestants. What's one of the main over-the-counter decongestants? You have to show your ID for it. That is Sudafed, right? Because, potentially Sudafed could be manufactured and made into methamphetamine. as the show Breaking Bad taught everybody. So we want them to stay away from cold meds because Sudafed and some of the other over-the-counter cold medications increase blood pressure quite a bit. So anything, obviously, that's going to increase blood pressure is going to put more strain